All right, let's jump right into it. Today, we're talking about chronic pancreatitis, and we're going to do a real high-yield clinical guide. This is all about the essential stuff you really need to know, whether you're at the bedside or in the clinic.
So, here's our game plan. We'll kick things off with what chronic pancreatitis actually looks like. Then, we'll put on our detective hats to figure out the cause. From there, we'll get into the diagnostic toolkit, how to manage the big issues like pain, and wrap up with how to keep an eye out for long-term problems.
Okay, first things first. What is chronic pancreatitis? Let's really get into recognizing the clinical syndrome.
So, picture this. Your patient comes in and they've got this just relentless abdominal pain. Maybe they're losing weight and they mention having greasy stools. Ding, ding, ding. This scenario should immediately have you thinking, could this be chronic pancreatitis? This is that classic presentation you absolutely can't afford to miss.
So what are we actually dealing with here? The key word on this slide, the one you've got to lock in, is irreversible. See, this isn't just some temporary inflammation we're talking about. It's fibrosis, it's destruction, it's permanent. And that's absolutely crucial, right? Because it means our whole management strategy is going to be about replacing the functions that the pancreas has lost for good. Right, and we all remember this from med school, don't we? The classic triad. You see calcifications on an x-ray, the patient has steatorrhea, and they've developed diabetes. But here's the real-world pearl. If you're seeing all three of these things, you're late to the party. The damage is already extensive. Our job as clinicians is to catch this disease way, way before this full triad ever shows up.
All right, so we know what we're looking for. The next big question is, why? Why is this happening to our patient? This is the detective work, and it's so important because the cause is going to guide everything we do next.
Okay, here are the usual suspects. And for anyone in training, you need to laser focus on the top two, alcohol and tobacco. These are by far the most common culprits you're going to see. And you know what? Counseling your patients to stop is probably one of the single most important things you can do for them. Of course, you've also got things like genetic mutations, which are a huge deal in younger folks where you can't find another cause, and even autoimmune issues. So, your clinical suspicion is high. Now what? Well, now we have to prove it. Let's open up the diagnostic toolkit and see how we can go from suspicion to confirmation. So, where do you usually start? A lot of the time, it's going to be with a CT scan or an MRCP. And yeah, they're pretty good for spotting the really obvious late-game stuff. You know, big calcifications, a pancreas that's all shrunken down. But what if the disease is early? What if the changes are subtle? For that, the real gold standard these days is endoscopic ultrasound, or EUS. It's just way more sensitive. And this table really shows you why EUS is the king. This is the Rosemont classification, which is basically a scorecard for diagnosing chronic pancreatitis. You're looking for a specific combination of features. So, for instance, if you see one major A feature, like actual stones in the pancreas, plus at least 3 of those minor features, that's enough to be consistent with the diagnosis. It's this system that lets us be much more precise and catch the disease earlier. Okay, diagnosis confirmed. Now the real work begins. Your focus completely shifts to management. And you got to think of this as a two-pronged attack, because we're fighting the two biggest problems for these patients, that awful, constant pain, and the fact that their pancreas is slowly shutting down. Look, having a systematic approach like this is going to be your best friend. It keeps you from missing things. So, step 1, double-check that diagnosis and go hard after those modifiable risk factors. Step 2, before you do anything else, make sure there isn't a complication you can fix, like a pseudocyst or a blockage. Then, and only then, do you dive into the long-term management of pain and insufficiency. And this really breaks down those two battlefronts. On one side, you have pain management. That's all about symptom control. We're talking lifestyle changes, pain meds, and sometimes even procedures to relieve pressure. Then, on the other side, you have insufficiency management, and that is all about functional replacement. We're literally giving the body back what the pancreas can't make anymore, those crucial digestive enzymes and insulin. Okay, let's talk about that exocrine failure. Pancreatic enzyme replacement therapy, or PERT, is the absolute mainstay. And listen, this slide is super high yield, stuff you will actually use. The starting dose is about 500 lipase units per kilo per meal, a typical dose for an adult, somewhere in the 25,000 to 40,000 unit range. And then you just adjust it up or down based on their symptoms. The key is to make sure they take it with every meal and even with snacks. And finally, we have to talk about the long game, because managing chronic pancreatitis isn't a sprint, it's a marathon. This is about looking years, even decades down the road, and constantly being vigilant for the serious complications that can pop up. And let's just start with a number that should get your attention, 4%. Over 20 years, patients with chronic pancreatitis have a cumulative 4% risk of developing pancreatic cancer. That might not sound huge, but it's a significant increase, and it's the reason we take long-term surveillance so seriously. So beyond just cancer, what else are we looking for? Well, there's the inevitable march toward diabetes as the endocrine function fails. You've got to watch out for metabolic bone disease, think osteoporosis, because they're not absorbing those fat-soluble vitamins properly. And then there are the plumbing problems like the bile duct or the duodenum getting squeezed shut by scar tissue. It just goes to show you this isn't a one-doctor job. These patients really need a whole team and consistent long-term follow-up. So let's end with a thought for the future. Right now, so much of what we do is reactive. We're managing complications after the damage is done. But what if that could change? As we learn more about the genetics, about the real root causes of this disease, could we see a shift? Could we move from just managing the fallout to actually stopping the progression in its tracks? It's a really exciting thought, and it means the whole outlook for these patients could be completely different, maybe even sooner than we think.